Good evening, everyone. Welcome to the 13th Seng Distinguished Lecture Series. My name is Tian, and I'm your MC for today. Thank you very much for taking the time to join us online today for this new evening time slot. Today's webinar is organized by the Boon Khim Mind Science Center with the support from Mind the Gap 200. Towards the end of the webinar, we will also be conducting a Q&A session with the speakers. Kindly submit your questions using the Q&A button below. Please note that this webinar will be recorded and posted on our YouTube channel. If you would like to receive updates on the upload, please consider subscribing to our YouTube channel and enabling notifications. Without further ado, I would like to pass the time to Emeritus Professor Heok. Prof. Kwa, please.
Thank you, Yi. A very good evening to all of you. It is a warm evening here in Singapore. My friends in Australia tell me that it is sizzling hot down under, and other friends in Beijing told me that it is freezing up north. We are now in the 13th Tao Tian Seng Distinguished Lecture Series, and this lecture series is to promote mental health, and it is possible by a generous donation from our friend, Mr. Tao Heng Tan, in memory of his father. His father, like all our forebears, came from China as poor immigrants, and he worked as a waiter for the British Merchant Navy. And despite his poverty, he would imbue in his children a sense of care, love, and empathy, which are still very precious values today in the world that is in turbulence, especially the sorrows and the destruction in the Middle East and in Ukraine. So those are precious virtues which his father instilled in the children. This is the 13th Tao Tian Seng Distinguished Lecture Series, and we have three wonderful speakers. The first is Professor Norman Sartorius. He was formerly the Director of Mental Health at the World Health, Geneva, and also later the past President of the World Psychiatric Association. And Norman is very evangelical. He would go around the world preaching the gospel of good mental health in Asia, Africa, South America. And his input in Singapore firstly, he helped to set up the Early Psychosis Intervention Program, the EPI program, and also the program on addiction. Some years ago, our professor from Oxford came to Singapore, and he asked me about our research here, and I told him that we are collaborating with Professor Sartorius, and he told me, Norman Sartorius, he is the most brilliant mind in psychiatry on the planet. And so shall we welcome Professor Norman Sartorius.
Thank you very much. Thank you very much for this very kind introduction. I shall speak about the urbanization and mental health because I think it's something that has become even more important now than it was before. The world at present is under the impact of a variety of major socioeconomic trends. One of them is the digitalization, which on one hand has helped us to manage data much better, but it is also contributing to a dehumanization of our society, particularly medicine, but also other disciplines. The other trends which are listed here, I will not spend much time on them, but I think we should just keep them in mind. One of them is the trend of commoditification. This is a recent development in which everything is taken as a commodity, which can be purchased and sold. Healthcare is a commodity. Directors of hospitals have become economists rather than doctors. Variety of other things, everything has to be expressed in terms of money, and if it brings money, it's good, and if it doesn't bring money, it is less good. And I think that that's phenomenon of commoditification has been a major influence on care, on healthcare, and in many countries, healthcare for the poor has become worse, and healthcare for the rich has become much better. Another phenomenon, another trends which I mentioned here is the fragmentation. Medicine as well as society is split into a huge number of sub-disciplines, and this fragmentation makes it in fact very difficult to see the person, the human being as a whole. There is a specialist for the eye, and another specialist for the ear, and another specialist for the nose, and there is all sorts of specialists, and including also within psychiatry. There are now a variety of subdisciplines of psychiatry which are supposed to be working together. After all, we know today that very few people are sick with only one disease. It is usual that people have comorbid diseases, several of them, depression and diabetes, for example. And therefore, it should be normal that doctors who look at them see both the diseases and the human being behind them and deal with the disease in this way. But the fragmentation of medicine has unfortunately become so strong that it harms the normal treatment of people. In some countries, for example, in the United States, they've invented a new category, which is duty of the person who is in this new category, a care manager. He takes the patient from one doctor to another, so that there is nobody who looks after the patient as a whole. They are all looking after bits and pieces. Demographic changes, of course, are present everywhere, with a huge increase of the elderly population, who are not only elderly, but very often also have diseases. And that one, I think, is something that we should keep in mind in thinking about healthcare for the future. And then the final trend is that of horizontalization, in which it is now more and more frequent that people are talking to each other in horizontal layers, such as, for example, adolescents speak to other adolescents and develop a language which only they understand. And other people within the profession, they speak also within the profession. And the consequence of that is, of course, that people understand each other much less well than before, and there is very little transmission, what one calls vertical transmission from parents to children, and that is, of course, contributing to the difficulty of maintaining social norms and behavior in a society. These are various trends. I'm mentioning them in passing because our main trend today that we'll examine is urbanization. Next, please. Here is what are the benefits of living in a town, and many people are attracted by them. You have access to specialized services, provided, of course, that you pay for them. There is access to most products. Everything is available in town. There is easy access to clean water, regular disposal of garbage, transportation facilities. Not everywhere equally well developed, but all of these are very often present and available. And I think all of these amenities and wonderful things in towns are providing, of course, are available, provided that you have sufficient money. But in many towns, even without sufficient money, you live a life which is much better than otherwise. Consequence. Next, please. Well, now, however, that has consequence of urbanization is that some of the people who have moved from villages to town find a way to benefit from all these urban benefits. But at the same time, other things have happened. There is now people, the young and able people have moved out of the villages, and the villages have become invalid. They are now containing mainly people who have a disease, disabled people, mentally retarded children or adults, and they live these villages which have it's not a community any longer. These villages live from what their children send them or do not send them from town. Some other villages have turned into dormitories in which people come to sleep, but during the day they are absent. So the notion of the village as such in many countries have been completely changed. And with it, also the notion of the community care. What we were talking about as community care, suppose that there is a group that knows each other, that speak to one another. That is not happening in towns. Many of the newcomers end up in slums. Slums have grown worldwide enormously. In some countries, the people who are a little bit better off, the middle class, has separated themselves from the rest, from the slums, into what has been called the walled communities. Around the middle class settlement, there is a wall, and on the wall there is barbed wire, and there is a person with a machine gun who stands not allowing anybody from the slums to get into the world community. Sometimes this is a very strong, but very often it is a little bit less strong, but still very visible. And of course, there is also a certain amount of conflict and difficulties because people who come from the villages and those are seen as, in fact, intruders, and the people in towns are reacting sometimes in a very violent form. All of these things are happening at a time when urbanization is faster than ever before. There are now countries in which practically everybody is a migrant to town or citizen of a town. In Argentina, for example, 95% of the population have now become urban, many of them living in very untoward conditions. Next, please. Now, here are some of the consequences of urbanization in general. One of them is what has been called anomie, that people who live in towns, they don't know anybody, nobody knows them. They are isolated and lonely, and they live in the town without really having contact. One of the great problems, for example, that has now been reported from China and from Japan, has been loneliness. Thousands of people are very lonely. The statistics show very striking figures. They show, for example, that people who have died, about 15% of them are discovered dead only a year later because nobody has been visiting them for a year or longer. And I think that that's something, this loneliness is a very important phenomenon, in part due to what I mentioned earlier, the horizontalization. Elderly people have lost contact with those who are younger. They are helping or knowing each other. And as they get older, this becomes less and less possible. And so they are very lonely and very often die alone. Towns also introduce a sort of fear of contacts with persons whom you do not know, because they may be robbers or thieves and they may be running away, you never see them again. In villages, this was never the case. You knew everybody who was there, and their village was as such, was a territory in which you could talk to anybody because you knew everybody, or the newcomer who were in there, they had also a stable community which they have attached. Victims of crimes have grown in numbers in most towns of the world. And it's very difficult now to see towns which have thought sufficiently to create a contact with nature, bigger parks, or other territories in which one would remember that one is alive. In many countries now, there is children do not even know to recognize, for example, a fish because they have been eating food which has been prepared and the original animal has skipped and nobody showed it to them. And usually in many towns, as the migration increases in speed, the capacity of the urban agencies becomes insufficient. And so the garbage disposal has been a big problem in many cities that we know, including also the huge amount of environmental deterioration because of the huge amount of garbage that is being thrown into a river or left around town. Next, please. Now, the consequences of urbanization are listed here. On one hand, since the diminution of family size, people living in smaller apartments, and the absence of the community means the children never learn how to deal with other people. They grow up without social skills. The urban schools are reporting a very important increase of child antisocial behavior. Suicide rates have grown, and willful school dropouts, because so many of these children, they don't know, they are not a community, and the teachers are also very often from different towns, so that the cogency and the coherence of the school has unfortunately been destroyed in many places. There is a higher incidence of mental disorders among carers, because much of the care for people with chronic illness, mental and physical, as well as care for the elderly, is left in the hands of some carer. And this carer not only has to work and make money to survive, but also has the huge burden of looking after a person who is either unwell or frail, or in other words, difficult. And of course, the homeless, mentally ill, and the drug users grow much more easily in the anonymity of towns. And that is something that we should keep in mind. Next, please. So I think that there are other consequences as well. Since the work is become very much a monotonous and fragmented, the probability of burnout at work has been increasing in towns very significantly. And there is also a significantly higher number of suicide of the lonely people in towns. And the probability of gambling in town has gone up, and the increasing pressure of health services has been a worrisome phenomenon as well. Next, please. So what should we do? I'm listing here some of the things that I think are of great importance. Number one, I would say we have to provide support to carers, to people who look after other people, by offering them training on how to provide care, by including them into the planning of services. They should be invited to tell us how best to organize services, what times to open or close the institution, and so forth, because they have to adjust to this. We should invite them to train health personnel. As somebody who's been looking after a mentally ill person for 20 years could teach medical students extremely well about what needs to be done and what they have to keep in mind. We should also give them money. Most countries of the world do not provide financial support to carers. And I think that that is something that we should think about. And we should think also of the health of carers, which we are often forgetting. Next one. We should think about of primary prevention and of quaternary prevention. Primary prevention is preventing the disease, sometimes very easy. For example, making sure that great care is given in schools to detecting children which have a slight hearing deficit. Because if it's not discovered, these children will be considered stupid. They are not obeying rules or orders because they don't hear them. And that will be gradually leading to their dropout from school, to drug dependence and other things. So we should think of measures such as control of hearing deficit, of visual deficit, providing women with an appropriate iodine supplementation, etc. There's a number of measures of primary prevention that we should do, which are particularly important in towns. The prevention of quaternary handicaps is also very important and deserves new attention. That is, thinking of ways in which we can use the disabled person to give them an opportunity to find a way to live, to make some money, and to live on their own. Those two, that is the primary prevention and this quaternary prevention, are deserving our major attention. The prevention on impairment and disability is doing quite well in recent years. Next, please. We should think about also with town authorities how to create conditions which will make it easier to live in towns. Common territory, for example, building safe spaces for adolescents have been mentioned as a very important way of doing it. In Australia, for example, that has taken a government program of major importance. We should adjust the mental health services to the condition of work in town. I'm remembering always a service that was dealing with towns, and they complained to me that they in fact never see particularly elderly people, forgetting that this particular service was located in a very busy crossing of roads, and it was a great skill to get to the service, so nobody got there. And we should think very carefully, where do we place the services, for whom they are to be, what can we do to involve the services in making life for these people a little bit better. Schools, of course, I do not have time to speak about the healthy schools, but there is numerous things that we can do about schools in towns to make things better. And of course, we should think about the health services in towns. They must include not a separate mental health service, but a mental health service which is included into the general health care services. Next, please. So, ladies and gentlemen, living in towns, I think, is the future of mankind. Unless we properly manage urban living, learn how to do things, we will have very unpleasant, harmful consequences for all of us. There is numerous measures which we can take now, and that is measures which are not requiring too much effort to help people who are living in towns today, but more so to help their children to live better. I think they should start promoting the quality and length of life in towns because it's possible, and we should start now. Thank you for your listening.
Sartorius, the question and answer will be a later time. I want to move on to the next speaker, and she is Professor Shefaly Shorey, and she is the Vice Dean of Medicine at the Yonglin School of Medicine, and also the Director of the Khim Mind Science Center. She started off as a nurse, and then her PhD, and went on to an academic career. Excellent teacher, researcher, and also administrator. Should we welcome Professor Shefaly?
Thank you very much, Professor Kua, for your kind introduction. It's always an honor, and rather it's very hard to fill in the shoe of Professor Norman, who presented very well. And thank you very much, Organizing Committee, for giving me this opportunity to be here today. And I hope I could see some comments that you were not able to hear. I hope my audio is okay. Do give us comments or thumbs up. Okay, lovely. And I think one unique thing when you are associated with the webinars with the Mind Science Center is the uniqueness of the topic, uniqueness of the different expertise coming together and sharing our insights. You have heard about urbanization and the mental health. You will hear about, youth and adolescents' mental health. And here I am coming about mental health in pregnancy. And I will be giving a little bit of a snippets on this approach, which is called the psychological first aid, or rather the research we have done at Mind Science Center, and how we are hoping to bridge a gap with pregnancy and childbirth. So I'm going to use some technical terms, and I will try to go slowly to explain. I have about 10 minutes, and I'm watching the time very closely because we really want to talk to you through question and answer so that we can answer your questions, right? So what is perinatal mental health? Perinatal is a period right from pregnancy all the way up to first year after childbirth. That period, pregnancy, intrapartum when childbirth takes place, and period immediately after childbirth, which is also known as postpartum, is known as perinatal period. And we're going to talk about mental health during perinatal period because being coming from Singapore, a multiracial society, I have been working with parents for the past 2 decades. And I have seen even until today, things are changing. We are making small steps, but still there's way to go where especially the happy occasion, pregnancy and childbirth is associated with the mental health. Still people see it as a taboo to talk about their mental health needs. But I want to share with you some scary figures. Globally, it shows that 10% of pregnant women and 13% of women in the early childbirth stage, they experience mental disorder. It can start just from blues and it can go into full-fledged depression. In Singapore, we have done research which shows that depression can go up to 11.9%. That means 1 in 10 women, they experiences depression during pregnancy or childbirth. And even anxiety is even higher. 1 in 4 women during pregnancy and 56.7 after childbirth can feel anxiety. And what I want to emphasize in my presentation today is all this while, as healthcare professionals, we have focused on the mental health of the mother, and which is important because mother's mental health, it also influences the long-term health of the child. And I will give you one example from one cohort study which we are doing in Singapore. But I think one key thing I want to emphasize today is, and I hope if you can forget everything what I've shared, but to remember this, that mental health of the women doesn't just affect or influence the health of the baby or the child's growth. In fact, it also influences the mental health of the spouse, the partner, the husband, because when the woman stays in a low mood or in a depressed state, it also takes a toll on the family members, especially husbands. So antenatal depression is linked to pregnancy complications. For example, women are seen having premature birth. We call it a preterm birth. It also affects the overall quality of life because you remain in a low mood, so-called which is a happy occasion, is tend to have more gloomy period for mothers, and it also influences their appetite, that means nutrition, as well as the sleep. And all these things indirectly affect baby's health, and I will share with you in my subsequent slides how. And there's a high risk for suicide among mothers, those who tend to be in the low moods, and also there's an increasing likelihood of developing mental health disorders after they have childbirth. That means after 1 year, everything okay, then later part in their life, they tend to have depressions and anxiety. I'm going to introduce this concept, which may be new to some people, and some of you maybe have already heard. It is called the first 1,000 days of baby's life. That's one of the key window, when we can provide the best start to our children. So basically what 1,000 days is, and just want to let you know that it starts during pregnancy. In fact, many of us have started working even on preconception. That means before even a couple become pregnant, but right from pregnancy all the way up to the 2 years of child's life. That's the 1,000 days, which affects that's where the baby's brain and the body organs they develop, and that's when the mom is having mental health issues, it influence the baby's child growth. So this is what I wanted to show you in figure. Pregnancy, which is about 270 days, and that's when the fetal development takes place. And if mom's mental health remain low, moods and depression and anxiety, it has future health implications, even not just to the child after birth, but during childbirth. Mother may end up having a preterm birth, for example. And during the infancy stage, which is the 1 year after childbirth, mothers who are depressed, and in fact, I have done one research which hasn't published yet, but I'm very happy to share with you how we have collected data. So we have looked for mothers who have score higher. We call it subsyndromal depression. That means those mothers who had a higher risk of having depression. We went to their home. We asked them to do a small activity with their baby, for example, changing a diaper. And we actually video recorded the mother and the baby, and we wanted to see how these mothers react to, how sensitive they are to the baby's reaction, how they show bond and attachment with the baby. And the mothers who are having a higher risk of depression, or they are at risk of depression, they don't realize it. We showed them the video afterward. They could see that making even an eye contact with the baby was missing in those mother and child diets. So it does influence to that extent that if mother is not mentally healthy, it affects the child, especially the first 1 year after childbirth. And in fact, into the next year, which is make the total 1,000 days window, because the children, the 2 years old toddlers, they tend to have attachment issues, and even it affects their learning environment and social interactions. And I could see, and I hear from Prof. Goa earlier, that the people from different parts of the world, they are joining us on this webinar. And I want to share with you one cohort study. What is cohort study? Cohort study means we start collecting data. We start collecting data from these people in a research, and then we follow up them for years. These are called cohort studies. And I'm very proud to share one very landmark cohort study we have in Singapore. We call it Growing Up in Singapore Towards Healthy Outcomes. Very commonly known in our newspapers and in our news articles, called GUSTO. So what we did about 15 years ago, we started collecting data from mother and the child, right from pregnancy all the way. And we are still collecting data from mother child. In fact, we have started now collecting data from daddies. We have even started collecting data from grandparents. And these family units are now 15 years old. For the past 15 years, we are regularly collecting data. And the data is not just, we ask them, how do you feel, or interviews. It's not just self-reported. We are in fact taking very invasive data, for example, brain scans of the baby, how they are doing and all that. And in fact, the GUSTO studies has shown that the mothers who showed distress during pregnancy, that their children, there was changes in their brain development when they are in their teenage age. In fact, it has shown that mother who had an antenatal depression, it has impact the brain regions of the babies and how they socially, psychologically, and even academically react at the older age, these children. So it's an invasive, both objective and the subjective data we have collected, which shows that how important it is to take care of mother's mental health. So what we can do about that? For the past 20 years, I've been developing interventions. We call it psychosocial intervention for mothers. We are giving them educational materials, giving them videos, engaging different people to showcase to them that understand how important it is for you to take care of your health. And I'm telling you, it's been my 20 years journey. very, very hard to convince mothers because they always put babies first, but they don't realize that when they're not taking care of their own mental health, indirectly, they're actually doing harm to the baby. So I always use this metaphor with the parents. We can never pour from an empty cup. So if this mom, she is not mentally, physically ready to take care of her baby, it will influence baby's attachments, development, so on and so forth. So what we have done, other than developing educational materials and all that, and I'm going to link two of my studies together, especially because Professor Kua wanted me to speak about psychological first aid, where we use brief integrative personal or psychological therapy to train the people who have at risk of depression. They are not diagnosed with depression, but they are at higher risk of getting depression. So I'm going to share with you this paper, which we published a few years back. So in fact, this is how I got connected with the Mind Science Center, which I'm directing now. So we did this study. This study was done on community dwelling older adults, those who had a subsyndromal depression. It was a randomized control trial. Sorry for the technical terms, but in very simplified form. And in fact, the name for this study, where there is no psychiatrist, came from Professor Kua, because he himself is a psychiatrist, and we know that psychiatrist to the patient ratio the gap is widening in Singapore. We don't have enough mental health care providers. So what we wanted to do is, can we support peers, those who are in the community? We can train them so that they can support the other people from the community. So basically, we train a group of nursing students, other elder adults, and we give them this BIPT training, which I will share with you how we did it. Of course, they have to be counter-trained. It was like train the trainer session. It's not just anybody can do that. And we also introduced mindfulness and few other options for the older community dwelling older adults, for them to feel better, especially when they were going to the community settings. And this paper is one of our highly cited papers. So what exactly we did, just a little bit on that paper. Our aim was to reduce their distress and improve the short-term and long-term adaptive functioning of these older adults. And of course, our interactions were very purposeful, and we wanted to provide them emotional support and guidance, how they can reduce stress in their life. And very much we use their own life's remnants therapy. That means using stories from their past, how they were able to overcome some of the challenges and then restore those coping skills. And of course, tapping on the strengths of the individuals rather than giving information from outside. So what this BIPT did, it identified those who were at risk for depression and provided them the support. It was given by the other peers. And we use like different combination of interventions, for example, remnants therapy, solution-focused therapy, mindfulness, and we take into account the needs and the goals of the individual. And it was very individualized. It was very personalized. Why I'm sharing with you this is because what we saw the success in the community dwelling older adults, and now we are introducing it to the pregnant women. How other women who have themselves gone through depression or anxiety when they gave birth, now how they can support this younger group of women who have gone through this journey, so that they can use some of their own personal experiences to guide these women. So this is my last slide to just give you what this BIPT exercise of the intervention we had was. So we will have a befriender, basically to get a peer, to have a relational engagement. And it has to be someone people can relate to, because if it comes from somebody they can't relate, for example, if somebody is an older adult, we try to have a peer who is from a similar age group. So similarly, for the pregnant women, we have started matching of these peers. We are trying to get the peer mothers who are also with having the same background. That means if they have a first child, so one child, we try to have them befriended with another mother who also have one child. If it's a multi-children families, we tend to group them together because the needs evolve according to the individual needs of the people, according to their kids' age and the stages they are. And then, of course, detecting early signs of mental distress by having a good rapport with them and finding out, because nobody will, especially in Asian context, very difficult for someone to openly talk about their mental health needs. You need to, and you say, suddenly, Shefaly, this stranger coming to me and telling me, tell me how you feel. Do you have any mental health concern? Nobody will open up. So building that rapport, we go through a half a day of a training on giving them the communication skills required so that they can have active listening and they can show the required empathy. And we are also introducing mindfulness awareness, because many a times when anxiety hit in, we are thinking either about the past or what is going to happen in the future. So what we are trying to give through mindfulness, this training, is that they stay in the present and savor the moment. And the mindfulness training is done by a separate group of mindfulness trainers, because it is not just simply a breathing exercise. You need to be a trained professional to provide this training. So we actually layer that with a multimodal approach of this support system. And then we also bring in solution focused therapy, where we were asking them from their past, how maybe from their childhood, whether their younger days, for the mothers, for example, when they were not pregnant, how they were managing some of similar stressors when they felt before. And of course, ethical issues are very important. We know as a peer, when we provide support to others, sometimes it takes a toll on the peers themselves. Peer stress, or we call it people can burn out. It's a real thing. So how we ethically remain within our research boundaries and intervention boundaries, and also support these peers, that's very important, and we pay very important attention to that. And of course, also introducing self-care activities, not just so there's a dependency on the peer. Of course, they can refer them to the different referrals we have. But if a person becomes suicidal, for example, they know, these peers know where to look after, or where to go to, or where they can refer this person to, because it cannot take a toll on peer, because you're always in a worry. I am working with somebody with a mental health needs, and I'm not sure when going to be an emergency situation. So when we are planning such programs, we ensure that the peers who are supporting other peers, they are also well supported. So on that note, I want to thank you all for joining us in the evening. Those who are in Asian region, but otherwise those who are coming from different parts of the world. And please stay connected. This is my email address and my webpage on LinkedIn anyways, and otherwise I'll be around to answer any questions. Thank you. Over to you, Professor Kua.
Thank you very much, Professor Shefaly. Always a very engaging speaker. Our next speaker is Dr. Tina Tan. She's a psychiatrist. I remember when she was a medical student, she came to see me, was very interested in psychiatry. And later on, I met the father. The father was very supportive. And I'm glad she is now a very well-trained psychiatrist. But she's also playing a big role in educating our doctors. She is the editor of the Singapore Medical Association newsletter, and also a council member of the SMA. Dr. Tina Tan, please.
Thank you for the introduction, Prof. Kua. Let me just share my slides. Okay, so my portion of tonight's talk will be just a very brief overview on depression in youth and seniors. And let me give a little brief introduction on what depression is from a clinical perspective before I dive into how it looks like in youth and in elderly. So from a doctor's point of view, we actually draw from two different sources, the ICD-10 and the DSM-5. The DSM-5 lists depression as someone with depression as having 5 or more depressive symptoms over a 2-week period with low mood and or anhedonia. Anhedonia just means that they don't feel any joy or anything, they don't feel pleasure in the things that they do. This causes clinically significant distress or impairment. And a little bit of factual information locally, the Singapore Mental Health Study in 2016 showed a lifetime prevalence of depression in 6.3% of the adult population, with women being more likely to have depression than men. Additionally, more recent subset of the study showed that 1 in 7 youth reported severe or extremely severe symptoms of depression. And conversely, in the elderly, there was an older study from 2013 called the WISE study, which showed that around 1 in 27 older adults had depression. And these individuals had a higher likelihood of developing dementia, which is something to be very mindful of. Okay, so what does depression actually look or feel like? In the youth, early signs can look anywhere from very obvious to not so obvious. And I've listed a few things here. It's not comprehensive. And just because a teenager in your life has these things doesn't mean that they have depression, but it's warning signs that you can look out for. So a lot of it would be like if your teen or the youth that you have at home or in your life starts to report things like stress, friendship problems, or if you notice they seem very hormonal, or you start saying that, oh, this is puberty, they might be going through a lot of mood swings, or if people start to say they're just being a teenager. But on top of it, if they start reporting that, they can't sleep, or they're constantly doom scrolling or brain rotting, which is the new term that, the kids from Gen A and Gen Z and Gen Alpha like to use nowadays. And sometimes just looking at their search history, some teenagers I know of, they share their devices with their parents, and the parents get to look at their search histories. And if the search history becomes very dark and very alarming, then that is probably a cause of concern. On top of this, something to watch out for would be things like tearfulness, mood swings, and a general withdrawal where they refuse to talk or engage, refusing school, or they're refusing social interactions when someone might have previously been very outgoing and very social. And more importantly, if all of this is occurring in a very pervasive and persistent manner, what does this mean? It just means that if it's happening all across the board, and it's been happening for quite some time, not just a week or two, but we're talking about 1 month, 2 months, even longer. So this is for what depression might look like in a younger person. On the other hand, in an older person, as Prof. Shefaly also mentioned, the study showed that there are a lot of elderly folk with subsyndromal types of depression. So it can be harder to spot. But sometimes the signs can be there in our elderly parents or in our elderly loved ones. Again, similar to youth, a lot of times older folk with depression or mental health issues might say that they can't sleep. And older folk with depression are often quite anxious. So they might not say that they're sad or depressed, but they might say that they are constantly anxious or worried about something, a feeling that there's something wrong. And then there might be a lot of avoidance behavior where they just don't want to go out, don't want to do anything. Previous things that they might have enjoyed, they just say that, no, it's no fun, I don't want to do anymore. Another important thing is an older person might suddenly not feel like eating so much, and you might notice a dip in their appetite or loss of weight. More importantly, the last 2 points where there might be a lot of physical complaints or somatic complaints alongside of genuine health problems. So what do I mean? Oftentimes, a elderly person comes to me for treatment after a series of health problems, and these health problems really did occur. Like they might have had like some kind of chest infection, or they might have had a series of giddy spells that require hospitalizations. And then after that, they might develop depression or anxiety as a result of all these health problems, which in and of itself might produce even more physical symptoms. Then lastly, to note, depression in an elderly person can be a precursor to memory issues, but it can also be a sign of memory issues in and of itself. So this is something to watch out for in the older folk in your life if you notice any of these things. Okay, so then I'm going to talk very briefly, again, this is not comprehensive, about the management of depression. What happens if you have a loved one in your life and you notice that, okay, they might fit some of these signs. Before I talk about the actual management, I want to briefly go over the warning signs that might warrant someone needing to get help. These might include inappropriate or unhealthy coping strategies. So I've listed here very briefly some things that you might want to watch out for, like excessive alcohol usage, the use of sleeping pills for adults or older adults. They might go to different GPs or different doctors looking for all kinds of medicine to help them to sleep because they don't know better. And then in younger people, there would be things like vape and K-pop, which, if you remember last year, the government took very, very active and strong steps to target this aspect of things. And in our youth, there would be more commonly acts of self-harm. Then on top of this, a person struggling with depression might have suicidal thoughts, even suicidal actions, which are driven by intense feelings of guilt, that life is hopeless, that one is a burden. It could progress into thoughts of dying, and then followed by active intentions and plans. So actually, if you think about it, oftentimes what an individual does, what they say or what they don't say, is inadvertently a way of expressing these thoughts. So it requires a lot of careful listening to really understand what someone is going through. So how is depression ultimately managed? Well, as a doctor, people come to me for medications most of the time. However, the government has made very concerted efforts to enable GPs on the ground, such as our family physicians in their clinics or polyclinic doctors, to be able to manage more simple mental health cases. And so I'm heartened to know that a lot of my colleagues on the ground are able to see these more simple cases. For more severe cases or patients who have safety risks, safety issues, they would be referred to a hospitalization, referred to hospital, so that they can be better protected in a secure environment. Then on top of medications, there's therapy. You could get a person to see a counselor or psychologist. And basically, I'm asked this question a lot. What is a therapist? What is a counselor? What is a psychologist? The easiest way to understand it is that a therapist is an umbrella term. Counselors are people who can see an individual on a very as-needed basis. Like if something acute happens and you need someone to just kind of hold your hand and guide you for a few sessions through that acute period. A psychologist can do that, and they can dig deeper into someone's personality, their childhood issues, the family dynamics, and kind of journey with a person over a longer period of time, 1 year, 2 years, or even longer. On top of this, it is not just up to the doctors or the therapists to help an individual manage their depression with medications and therapy. I always emphasize that individuals need to be diligent about making lifestyle and behavioral changes. This includes things like exercise and meaningful activities to help them get better from their depression. And also very important is to have a network of support, including family, caregivers, school for youth. Okay, and that brings me to the end of my segment. If you have any questions, you can put it in the chat. And I've put here a list of common resources that someone can go to if they have need. Thank you very much.
Thank you very much, Dr. Tina Tan. We come to the Q&A, and there's a question that was sent to me 2 weeks ago. It's from the chairman of the Public Housing Board or HDB board. Mr. Benny Lim asked me a question: how can mental health professionals help in promoting or improving the mental health in a public housing estate? So I wonder whether we can have Professor Norman Sartorius to say a few words. Norman, if you're living in Singapore and in a public housing estate where we see a lot of people with mental health problems, and how can we promote mental health in a housing estate? You mentioned some in your talk already, but what else can we think we can do?
Well, I think the example that you yourself have developed in thinking about ways of remembering that the housing estates are very difficult to control, to think about particular activities for example, for the elderly, which do things together on a given time. Being together is in itself an enormously useful activity. So maybe one can organize I was very impressed by the organized visit to the botanical garden, which I thought was a good example of bringing people out of the setting where they are anonymous, to come together, to see each other, to go together, to look at something and come back and remember that. I think that in other towns, they've tried now to develop a territory, common territory in which there is free water, no more than water. And people come there and sit down and drink a glass of water and talk to each other. And I think that very much depends on the country in which you are and the group that you want to involve. But there are numerous activities. None of these activities are sensational. None of them are revolutionary. They are small initiatives which try to maintain the contact between people, because that is probably the most important counter activity, counter depression and various other things that we have, is thinking about bringing people together again, that they have that they spend time together, that they listen to one another, and that they have somebody who listens to them, which is also very important.
I think what you mentioned is quite right, because some activities we have in Singapore, like singing, art, walking, people tell me, well, we know that already. But the Mind Science Center give you the evidence base, the science. We've done the research on it, we've done a brain scan study, and so we have a program called Age Well Every Day, for the community. We bring them up together to botanic gardens. So the strength of the Mind Science Center is we do the research and bring the biological studies that people become more convinced. Now, Professor Shefaly, the director of the Mind Science Center, are there any other things you can think we can do that to promote mental health in the HDB public housing estate?
Yeah, definitely. I think like what you mentioned, other than Age Well Every Day, where we are bringing our older adults to the community, I think we can go down to them by using peer support, for example. So I think that's one. PFA is psychological first aid is something we are now further extending it with 20 dwelling older adults. So we are waiting for the funds to come in, and we'll be doing the scans and very extensive report on the mental health, both self-reported as well as something which is delivered by the professionals like psychologists, and hopefully that will give us another evidence that they don't have to come, because I think that's one of the key things which Dr. Tina has mentioned. Those who are really needing a support, sometimes they are not able to even come out of the house, so we need to reach them. That's one. And I'm also answering Prof. Kua, if you allow me. I saw one question was directed to me in the Q&A, where they said that for the psychological first aid, especially for the pregnant women, they are at different stage of anxiety. How is the selection criteria? That's a very good question you have asked. Like we said, that PFA is not something which is diagnostic, it's a supportive intervention. So there is a cut-off screening for that. That means before we get a person suitable for this psychological psychotherapy kind of a support, we use screening tools. For example, there's this tool called GAD. We will look at those who are at low to moderate symptoms for anxiety. They get the chance to participate. Of course, those who have severe anxiety, they need support from psychiatrists. And again, Dr. Tina has very nicely explained what are the different levels of support. If it's an acute level, who can help, like counselors. But if it is something, even at a lower, milder level, if it can be supported by psychotherapy, for example, BIPT, that's where the psychological first aid comes in.
I think that question is asked by Mr. Clive Tiang, a Singaporean who is now in London doing his clinical psychology. Norman, you have a question? You have something to say, Professor Sartorius?
I just remembered one other thing that we found was very useful, and that is has been a change of the way in which social workers were doing their work. Well, previously social workers in Holland they had their office in a facility, and they were from that office they were looking after problems. They decided that they would do it differently. They took the social workers and they gave them 20 addresses, and the social worker had to go to these 20 addresses maybe once a week, maybe more often than that, and play a role, particularly in the somewhat elderly groups, etc., play a role of a extremely well-educated son or daughter who can help them in anything they needed. And it became amazing that, number one, the families who were visited were much more likely to get together, etc. And the social workers themselves have felt much better, because that was something that they were doing with people in direct contact rather than sitting in an office and phoning around. I just wanted to mention this particular project, which I think was good for the population, was good for the families, but was also very good for the health workers who suddenly found that they are dealing with human problems rather than with paper.
I want to ask Dr. Tina Tan. Tina, now with more GPs trained and in the housing estate itself, how can we help them, or how can you can assist them through your newsletter that can play a better role as mental health professionals now?
Actually, I think that in terms of GPs and polyclinics, there's been quite a good amount of effort that's been put into ensuring that on the ground there is a lot of accessibility in that sense. I'm aware that there are more and more GPs taking up the GDMH, the Diploma for Mental Health. So this enables them to kind of be equipped with the knowledge on how to treat mental health cases when patients from the heartlands come to them. At the same time, within the polyclinic setting, I am also aware that most, if not all, the polyclinics have things like their own memory clinics, and they have their own psychologists. Again, it makes it very accessible for people to be able to tap onto these services if it is needed. I suppose the important thing is there just needs to be more awareness that these services do exist. And oftentimes, people ultimately still come to me and they ask me, okay, what can I do? And when I direct them to them, they're like, oh, actually, it's really so easily within my reach.
Thank you. There are actually a lot of questions. I put them in the slide because they sent to me 2 weeks ago. I'm going to put on the slides and run through very quickly. So this picture is taken from an exhibition on a futuristic painting of Singapore. Everyone thought it was a beautiful painting, but then I thought, there's all buildings. There's no greenery down there. If you remember, the first Prime Minister of Singapore, Mr. Lee Kuan Yew, wanted Singapore to be a garden city, and this is supposed to be a future of Singapore. Well, I hope there'll be more plants in the island. Now, next slide, please. Some years ago, there was a conference here in NUS chaired by Professor Tomiko on the mental health of a nation, and he asked me about the health-seeking behavior. And we know that from our data that about 3 to 5% of people will seek help from specialists, and 15% to 70% to by GPs, but there are 20% of people undetected. So the question is, if people have mental health problems and not detected or don't seek help, what to do? So I'm very glad, as you have heard earlier on from Professor Shefaly, that we have started off a research called the Brief Integrative Personal Therapy. It's the idea of five colleagues, Professor Chong Pak Yen, a GP, Professor Goh Gan, a professor of family medicine, Wee Sin To, Frank Boon, and myself. We came together. We thought of this interesting approach that we should not all the time have just CBT or psychoanalysis, but also draw in what's appropriate from the culture. Mindfulness was one of them, and also the technique should be appropriate for a person, and also in all our approach, emphasis on healthy lifestyle. During my training in the UK, anything we just talk about CBT or psychoanalysis, but no one talk about healthy lifestyle. So I'm very glad that we do something that's interesting, has been published in the world's literature. Now, also, someone asked me, have you all done anything on intervention or prevention? And somebody from the ministry was telling me that it's no use just telling us the prevalence of the problem, the prevalence of depression, the prevalence of dementia. What can you do to prevent? And so that was one of the challenges we encountered. We started off the Jurong Aging Study. It was sponsored by the Guan Yin Hucho Temple. And in fact, part of it was included in Professor Sartorius' paper, The Advances in Psychiatry, published a few years ago, and we have health education, Tai Chi, mindfulness, art therapy, and there was also a lot of biological tests, including brain scan, immunological responses. And after 5 years, this is the response. Initially, about 9%. After 5 years, the prevalence of depression falls. With this intervention, a non-drug approach. Now, I also received a note this morning from Mr. Daniel Kuo and Fernley. This part of this study has been published in the molecular psychiatry because they also they found that people with depression, the aging process is much faster. The first study in the world. It's just been published today, in fact, from our data here. And then the study, after it's been done, we also extended to the rest of the island in a program called Age Well Everyday Program. And we are very glad because this program is still going on. This was part of the dementia prevention program. There are 3 big centers in the world, one in Paris, another in Finland, another here in Singapore. The project in Singapore that attracted a lot of attention is the people here are all volunteers helping out. And we didn't depend on the ministry or the government give us money. It was a philanthropist who came in to give us a lot of money. And now we are moving on to a very important study that someone asked me earlier on this morning also. When Singapore, before the colonialists, Stanford Raffles came to Singapore, the island was covered with the tropical rainforests. But things have changed. They've cut down all the forests for plantations and built a big metropolis. But as you look at the island of Singapore, the past few days, there's a haze drifting in. The haze in Singapore is because of the burning of the rainforest, And so we asked ourselves, is this going to be a garden city? What must we do? Now they rebrand it as a city in nature. And we've done a study, in fact, before the haze. We found that during the haze, the mental health of old people, especially those above 65, there's increase of depression and anxiety symptoms. So we have embarked a lot of studies on nature and mental health, and a paper was published also in the Scientific Report of Nature. But the lead author is the lady in white blouse in the center, Dr. Angela Sia, about therapeutic garden that improves the immune system. The paper was in fact mentioned in the BBC in London. And also because of that, there are about 20 therapeutic gardens in Singapore now. And we are very happy because, and very delighted because it's the idea that comes from the mental health professionals. And now we are moving on to another area which we think is terribly important, the rainforest. Because of the destruction of the rainforest, there's all the climate warming. Yesterday in Singapore, it was very, very hot, and it's supposed to be springtime also, but it's very, very hot. And it's a rainforest study that's attracted a lot of attention. We realized that people who are involved with us, the rainforest, develop a sense of empathy, also for their fellow friends. And during the pandemic, they begin to care for one another, and then they begin to care for the rainforest. In fact, this group of people walking there, they donated about $30,000 to the national park to plant over 100 trees. And this research been published in a book called Nature, Health, and Happiness. And apparently there's a small report in the New York Times about this study. And everybody that comes to the IMH, when I was a CEO, I'll ask them to plant a tree. And this tree was to provide shelter for Professor Sartorius, was a tree planted by Professor Roy Menninger from America. And 20 years later, it's now a big tree and it provides shelter for patients and staff, and also for Professor Norman Sartorius when he made a brief visit to IMH a couple of years ago. So what I'm saying is that whatever we do today and all the effort, it will also bear fruit in future. And it may not benefit us altogether here. And the rainforest is actually not only for ourselves, but also for the next generation. Professor Norman Sartorius has been to Singapore many times. As I mentioned, he's very evangelical to spread the gospel of good mental health. And you see, I think training education is very important. He's trained a whole group of of young psychiatrists in Singapore, Asia, and this is a club we formed called the Top Club, Teachers of Psychiatry Club, with a tagline, Psychiatry Sans Frontier. And sitting on his right is Dr. Chi Kwanzi, who is listening in now, and he told me that he's written a book on guide to psychiatry and hope more GPs will read the book. Professor Sartorius and I have also written editors-in-chief of the first world book on mental health, and it's called Mental Health and Illness Worldwide. There are 7 volumes, and I'm very glad that I'm one of his, 2 of us are chief editors. And the picture on the right was Professor Sartorius coming to Singapore some years ago under a spreading pine tree, and after a wonderful Teochew dinner in my house and a glass of wine, he thought about the idea of early psychosis intervention program and also addiction program. I'm very thankful for his contribution to Singapore psychiatry. And finally, I want to thank the many people who are helpful to our program on promoting mental health in the island, and also the research. Lee Sun Teck and his son have both passed away. Wonderful people give us a space at the Jurong Point Shopping Mall. Ling Ta Hua and Lucy. Mrs. Teo Po Yim was the late wife of the Deputy Prime Minister who suggested the Age Well Everyday program. And then Henry Lim, Wei Sin To, all this group of friends, Tao Heng Tan, who donated to this webinar, and Hong Hai, H. Tan, Chu Chao Bing, they're all part of this program and helping us tremendously. I want to thank all of them, and I want to also to thank now, because time is catching up, I want to thank all the speakers, Professor Norman Sartorius, Professor Shefaly, Dr. Tina Tan, and finally our two helpers here, Jia and Yi, and of course listening, I'm sure in his home, Mr. Tao Heng Tan, and of course our chairman, Mr. Abdullah Tamuji. And for all of you who are listening in, have a nice day, or what is left of a nice day. So thank you very much.
Thank you, everyone.
Thank you, Prof. Kwa. And thank you to all our speakers today for our wonderful sharing about the mental health of people in an urbanized environment. And with that, we've come to the end of the 13th Tian Seng Distinguished Lecture Series. Once again, thank you to everyone for joining us and for your contributions to the Q&A panel. When the webinar session ends, you'll also be prompted to complete a survey. Your feedback is very valuable to us, so kindly take 5 minutes to share your thoughts. Thank you once again, and goodbye.